My name is Beryl Benassaraf, and I'm a professor of radiology and obstetrics and gynecology at Harvard Medical School. And one of my passions lately is 3D ultrasound, volume sonography as I call it. And I think it's a very, very important new modality in ultrasound and imaging that I think has a huge future. And I'm going to be talking today about the applications of 3D volume sonography in obstetrics. Volume sonography, otherwise known as 3D ultrasound, is a new era in efficiency and diagnosis in fetal imaging, which I personally am very, very excited about. And I think for a while 3D ultrasound gave the wrong impression out there because people thought that it was all about just getting pretty pictures of the face like these. And in fact, it's a lot more than getting pretty pictures. 3D is volume scanning. And it's all about how we can display that volume. With 3D ultrasound, you acquire an entire volume, which then permits you to render an infinite number of slices within the volume and of types of displays of the information. You can either slice it and dice it, or you can render the entire volume as a surface, for example. But the volume contains all of the information that's available. And it's up to us to display the information that's within the volume to advantage so that we can show what we want to show. So we've only just begun to explore the ways that we can display the information within that volume. So today I just want to talk about really 4 of the main display modes that we have to tease out the information, the sonographic information within the volume. The first one we'll talk about is surface rendering at an interface, and for that you need to have enough fluid at the interface to be able to render a surface. The second one we'll talk about is 3 orthogonal planes. These are 3 planes that are at right angles to each other that intersect at one point. And it's the main way in which the volumes come up when you first take them. And you can navigate through that volume using those 3 planes. The inverse mode we'll talk about in a moment. And the tomographic cuts are parallel cuts. They're parallel to each other, much like a CT and an MR. So let's start out with surface rendering, which is at an interface. And that shows an image of the surface of an object. Of course, there has to be enough fluid in front of the object to form an interface that can be rendered. And this display can be accomplished in lots of different modes. You can have a soft tissue mode, you can have a skeletal mode, you can dial through a lot of post-processing modes to display what you want. For example, this is a 7.5-week fetus, surface rendered, showing the little head, which is bent over, and the yolk sac. And this is the 3 orthogonal planes showing you where that little tiny fetus is, and showing you the green line is going to give us the interface where we're going to render. And then in the lower right-hand corner, you see the rendered image showing you the little head and the yolk sac underneath. The fetus is looking like it's sitting on the yolk sac. And then, of course, you have the little limb buds that can be visualized. And compare that to the drawing of what a fetus looks like at a crown rump of 10 millimeters. Now here we have at 8.5 to 9 weeks, you can already see the enhancement that you get by doing a 3D surface rendering compared to a standard 2D crown rump image. You can see the fetal ear, you can see the little arm and leg buds much better than you can in 2D. And you already get an idea of what this embryo looks like. And you can compare that to the drawing, showing that the ear is actually fairly low at this stage, which is normal, and the ear eventually rises up to be about at the level of the orbit. At 12 weeks, we get a lot more information. surface information about the fetus. You can see the digits, you can see the eye, you can see a lot of details, better than you can see them in 2D. These are two little guys that came in to have their nuchal translucency measured, and here we're imaging them from the back, and I just want to show that you can see all 4 ears. You can see the both ears in both fetuses, showing you that in fact this is a great time to image the ears by doing surface rendering. And it's not something that we normally think of doing at 12 weeks, is to take a look at the ears. This is a fetus that has amniotic band syndrome. This fetus was about 11 weeks, and you can see that there are a lot of abnormalities here. There is a large encephalocele here. There is a large anterior abdominal wall defect right here. You can actually see the bands right in here and in there. But surface rendering shows you the information even better. It actually shows you a severe cleft right in the center of the face right here. And you can see that that cleft is a destructive cleft in that it comes all the way into the middle of the face and goes up into the large encephalocele, or acrania, if you will, where you have a large amount of brain that is not covered by skull. And you can see anteriorly also the very large anterior abdominal wall defect in this fetus with severe amniotic band syndrome. Now, sometimes it's important to try and get more information about a dead fetus. And many times, unfortunately, we are called upon to image a patient who's bleeding. And in fact, when we look, we find that the heart is no longer beating and the fetus has passed away. And of course, invariably, the mother will say, you know, what happened? Is this going to happen to me again? What did I do? And so forth. And if you can give her more information as to perhaps the fact that this fetus was abnormal, it is helpful. And in this case, we imaged the fetus in a surface rendering mode and found that kink in the spine right here that ended up just not being visualized at all on the 2D image. So this was very helpful to the mother to know that there was probably some sort of abnormality that was quite severe. Now here's another case in the late second trimester where we're doing a standard survey and we're looking for the bladder. And where is the bladder? Well, sometimes it empties out, as it does on a regular basis, but then it starts to fill very quickly. And if you wait for a little bit, you will see the bladder fill. Now here we are in the lower aspect of the fetus. This is the lower end of the spine here. And then we have the insertion of the umbilical cord right here and the genitals, but we don't have a bladder. Now the genitals do look somewhat abnormal, and I'm not really sure if we can tell whether it's a boy or a girl here, but there is no bladder. Well, one can infer that there is bladder exstrophy in this case, because the bladder not being filled is probably lying on the anterior abdominal wall. But what better to show that than a 3D ultrasound? And here on the surface of the anterior abdominal wall is in fact the bladder, which is splayed open in a bladder exstrophy right here. And this was in fact very helpful. Here's another case that came in because of a kink in the spine seen on another scan at another facility. And here is the kink right here. It's a hemivertebra. It's a vertebral abnormality. And when I took the entire volume to look at the entire spine all in one image, I was able to render it as a skeletal mode. And lo and behold, I saw that there was a rib missing. The absence of this rib was not something that I appreciated in 2D. And I went back to my 2D to see if I could appreciate it, and sure enough, by working hard, I was able to see it in 2D. But this was identified first in 3D, and it was not something that I had appreciated originally. Another thing that 3D surface rendering is very helpful for is to get the global picture of how the fetus is lying. 2D enables you only to get one thin slice at a time. And so you depend on getting a lot of little thin slices and conjuring up in your mind what the fetus looks like in 3 dimensions. But here you can actually display what the fetus looks like in 3 dimensions and get an entire view of the whole uterus all at once. And in this case, this fetus, who has arthrogryposis, has some contractures of the upper and the lower extremities. You can see that the fetus has hyperextension at the knee and club feet. You can see that better on this side. And you can also see the clubbed hand or the clenched hand because of the contractures, and this fetus is not moving at all. Now, 3D has helped us also look at the palate. Now, in this case, as you know, looking at the lip is not that hard to do. We can look at cleft lip and palate quite easily with both 2D and with 3D. But looking at the soft palate is very difficult and really has not been reliably done with regular ultrasound. But in this case, if you take a volume of a fetal profile, and of course the display is always in the upper left-hand corner, and here I'm displaying the profile, but I flipped it upside down. So the chin is up here and the forehead is down there. And you bring up your render box so that all that you're going to render is actually in this little box right here. And your point of view is this green line. And you put the point of view inside the mouth and look basically en face at the palate. And what do you see? You actually see rendered the entire palate. And this is a great new method of looking at the palate inside the mouth. Now let's look at an abnormal one. Here again, the fetus has been imaged in profile and then flipped upside down with the chin here and the forehead there. I've put in my render box with my point of view green box right in the mouth. And we're looking up at the palate. And what do we have here? We have a rent or a space right in the middle of the palate, a linear space. And in fact, this fetus had a normal face, other than some micrognathia or a small chin, but the lip was normal. So what do we have here? We have a cleft palate. You can see the cleft right here in the middle of the palate, and you can compare that to the normal palate right here, which is all in one piece. Compare that to the path specimen of this fetus who had multiple congenital abnormalities. So let's look at some clefts. Now in this case, we're looking at a cleft lip and palate. And those are easy to identify both in 2D and in 3D. But the 3D is helpful for the parents to appreciate what the child is going to look like, and also for the plastic surgeon who is not particularly trained in looking at cross-sectional imaging and ultrasound. So here you can see how similar the cleft is looking to the newborn, because there's a large hole right here and some collapse of one side of the nose. Here's another example. This is a cleft lip only. Now here the palate is intact. I'm not showing you the palate here, but the palate is intact. And you can see here that there's a cleft. This is on one side, and this one has it on both sides here. And this is particularly helpful because it really shows what the child is going to look like. And we who are trained in ultrasound can scan in 2D and sort of go in and out of the face and conjure up in our mind what that cleft looks like. But it's very hard to convey that information to the parents and to the plastic surgeon who is going to try and explain to the parents what kind of surgery is going to be needed. So this really makes it real and makes it helpful. And here is another fetus that had a bilateral cleft lip and palate. And just to show you how well these can be fixed by the plastic surgeon, this is the child after it had the surgical repair. Really a superb outcome. Now let's look at some ears and look at some dysmorphology of ears. You can see in this fetus with Down syndrome that the ear is in fact very small. And here is the ear right here and here. and it is quite small for the size of this fetal head. Now, we don't have many criteria for what ears should look like, and 3D is going to give us the opportunity to look at what the ear should look like and what the criteria should be for a normal-sized ear. Here is another fetus with Down syndrome, and in this case the ear is probably not necessarily small, but it's very low set and rotated forward. The bottom of the ear is rotated forward, which is also quite abnormal. And the dysmorphologists have a lot of information and experience in diagnosing low-set ears and in knowing what that means and what the syndromes are that can be associated with low-set ears. And now we have that capability because we're able to render the face and look at the dysmorphology that the geneticists do after birth. Here is this fetus with Down syndrome showing the protruding tongue because fetuses with Down syndrome have poor tone and the tongue tends to protrude. Another dysmorphic fetus. This fetus has a neural tube defect, and I'm sure you guessed right that the fetus has a neural tube defect, even though I'm not showing you a picture of the spine. What I am showing you is a picture of the head with a pointy head known as the lemon sign. This looks like a lemon. And I can also show you that the cerebellum is wrapped around the brainstem, and it looks like a banana, and that's the banana sign. The lemon sign and the banana sign are associated with the Arnold-Chiari type 2 malformation, which is in turn associated with an opening in the spine somewhere along the spine. So what this tells me is this fetus has an opening somewhere along the spine. But we don't know really what these fetuses really look like. And now with the 3D surface rendering, we can take a look at the face of this fetus. You can see the pointy forehead. Very funny looking ear here, a small ear, probably somewhat low set because the ear normally comes up to about the level of the orbit. And it looks like there's also a small chin, micrognathia. This fetus has a funny ear as well, but it also has hypotelorism. The eyes are too close together and the chin is very small. These are dysmorphic changes that we used to have a hard time discerning with 2D ultrasound. But now with 3D, we can display them almost as well as they are displayed later when the baby is born and we're looking. Here's another application for surface rendering, and that is the genitals. Now here are two different fetuses with ambiguous genitalia. This one here on the left has a phallus-looking area right there, and I don't know whether these are labia or this is part of a scrotum. And again, the same thing, a phallus and then either labia or scrotum. What do we do now? Well, we try to figure out if this is a boy or a girl by doing an amniocentesis. Well, this fetus is a girl, XX, and this one is a boy. Well, they still look the same to me. So then we do our 3D rendering, which is going to be very useful. And you can see here that there is masculinization of the clitoris right here, and that this is the labia right on either side. And that's very different compared to what we see here, which is clearly a boy that has severe hypospadias, where the penis is actually pulled down below the scrotum. That's why it's called penile scrotal transposition. It's a severe form of hypospadias. Now look at how incredibly different they look in 3D, but how similar they look in 2D. And this has been very helpful because then we can ask our colleagues in urology to help us make these diagnoses, because now we can render them in a way that they're used to looking at them. All right, let's move on to another type of display, the three right-angled planes, the multiplanar reconstruction. This is a type of display that shows you three planes that are at right angles to each other, and it enables us to manipulate the planes to get just the right slice. And that slice can actually be completely reconstructed. This type of imaging gives us the opportunity to make the acquisition plane irrelevant and to be able to display any slice at all that we want. This is a profile. Now this fetus was in a supine position when this image was taken, when this volume was taken, and yet I can display here the coronal view of this face even though I could not scan in that orientation. Now here's another a fetal head here, which shows you that we can scan in this view. That's the acquisition view showing you the lateral ventricles here. We can also scan at right angles to it, and in this case we're seeing the corpus callosum. But this view, which is the axial view, very much like a CT or an MR, is a view that we can't scan in. We can only reconstruct it. We cannot, in this particular fetus, actually come in and get this picture directly with 2D. How is that useful? Well, it is incredibly useful because in this third trimester fetus, whose head was way down, I wanted to image the corpus callosum. But there was no way in either of the two planes that I could scan in that I could display the corpus callosum. So I took a sweep right here and reconstructed the midline to show the corpus callosum. So I can reconstruct this view because it is in the volume. And all I have to do is figure out how to display the one view that I need within one whole volume. Here's another fetus that also has agenesis of the corpus callosum. And this little dot right here is actually on a cyst. Now this dot is the intersection between all three planes. So this dot represents the same space as that and the same space as this. The dot is on the cyst. This is an interhemispheric cyst associated with agenesis of the corpus callosum. And in this reconstructed view here, you can see the parallel orientation of the lateral ventricles, which is typical of agenesis of the corpus callosum. And that is in the reconstructed view that we cannot provide unless we take a volume and reconstruct it. And this is one last example. And in this case, we're in the skeletal mode. As you know, we have lots of different modes that we can display. And here we're showing the skeleton, much like the case that I showed you where the rib was missing. And this enables us to display any view within the volume of the spine. Now let's go on to the inverse mode. The inverse mode is very interesting. What it is it's a rendering mode of the entire volume. But it takes everything that is cystic within that volume and makes a cast out of it. So that everything that's cystic becomes opaque and everything that is solid melts away. So that what we're able to see, instead of, in this case, having one slice showing you these different cysts in a pelvic scan, you take everything that's cystic and make it opaque, and you can see that this is a hydrosalpinx. Now this hydrosalpinx comes in and out of multiple planes, so there is not one plane that will help you display this. But if you take the entire volume and push the one button to get the inverse mode, then everything that's cystic will become white. Here is another hydrosalpinx, and when we push the button, not only can you see that the hydrosalpinx is right here, but you can see the fimbriated ends of the hydrosalpinx, and you can also see the follicle that was sitting in the ovary that was above it in a different plane. Now, getting back also, the hydrosalpinx is particularly helpful to show in the inverse mode because these hydrosalpinges can go in and out of many planes, and there is no plane here, even in any reconstructed plane, that will show you the whole hydrosalpinx. But getting back to the fetus now, this is a fetus that has hydrocephalus. And it also has a funny cystic area right here in the frontal lobe and the frontal portion of the lateral ventricle. Now let's display that with inverse mode. And here we are. This is a cast of all of the fluid areas within the brain. And you can see the lateral ventricles, the entire lateral ventricles, as well as those cystic components in the frontal area. Here is a fetus that has hydronephrosis. And you can see the fluid in the kidney, in the collecting system of the kidney, and in the ureter as well. But this is only one slice. And this is the entire kidney, the entire ureter, all the way down to the bladder, seeing in inverse mode. And one last example, this is a fetus that has urinary obstruction. It has posterior urethral valves. And you can see the very, very large bladder that this fetus has. You can see the posterior urethra. And in this case, actually, you can also display the kidneys. And you can see that our dot, you see our little dot right here, our dot right there is on the descending aorta. And so that's what all of these three images have in common, is this one dot. So in fact, what these three images show is the bladder and the dilated kidneys in this patient with posterior urethral valves. Now you push one button and you have the inverse mode, and this shows you now the bladder and the posterior urethra very nicely. Going on to the last type of imaging technique that I want to talk about, and this is actually one of the most important ones, is the tomographic ultrasound imaging, TUI, and it's multiple slices that are all parallel to each other, very much like a CT or an MR. You can set the distance between the slices to be 1, 2, or 3, or 4 millimeters apart, depending on your subject or what you want to do. But basically here is a fetus that has mild hydronephrosis. And here I've taken one volume. And in this volume, I'm displaying these cuts going from the front of the head to the back. And the display goes from the front all the way through the cavum septum, all the way through to the back, to the choroids, and back here to the occipital horns. Now, having seen that, then I can say, okay, I'm going to go to a different orientation. I'm going to go to image B. And here we are now going from side to side. And I've arranged my slices to go from side to side. Now, this is not a new volume. This is the same volume. I'm just slicing it in a different orientation. And here I can go from one side with the choroid and the lateral ventricles, clear through the midline, showing the corpus callosum, and all the way out the other side to the other ventricle. Now, there's still one more orientation, the C-plane. And here is that coronal plane. This is the one that you can't even scan in. This is the one that you have to reconstruct completely. I'm going from top to bottom here, very much like a CT scan. And you can see the axial view of the entire brain this way. Now, you can also do this in a normal case. Now, here, for example, is a normal fetal head. And what can we get from this normal fetal head? Take one volume, and what do we have? We can look from the top to bottom of this volume. We can see here that we've got the posterior fossa. We've actually can measure the nuchal fold back here. We've got the cavum, we've got the cisterna magna back here. Here we can actually grab our BPD either here or here. Here we've got the cavum septum. We're coming up into the lateral ventricles and the choroids, and we can actually see the walls of the lateral ventricle and go all the way up to the top. We've actually got everything we need here to archive the anatomy of this fetal head. We just take one volume and we're done. Here's another volume of the body of the fetus. And this shows the chest and abdomen. And we're going side to side with these slices. And what do we have here? Here we have the diaphragm. We have the right lung. We can actually see the gallbladder right here. We can see the aortic outflow tract right there. You can also see the pulmonary artery outflow tract. You can see the insertion of the cord. And then you can see the stomach as we come into the left side, way over to the left side. And you can also see the insertion of the cord here. And perhaps maybe even a little piece of the bladder there. You can see a lot of information. You can also see the spine here in the back. So there is enormous benefit to this type of display. It's a type of display that CT and MR has had for years. All the relevant anatomy can be captured all at once. and the patient can be on the table for a vastly reduced period of time. And then you can do the entire scan on a virtual scan on a review station because you have all of the information as though you still had the patient. So that's why I think that 3D volume imaging is one of the most important advances in sonography, because finally ultrasound has acquired the same capabilities and hopefully the same type of displays as CT and MR. Because when you think about it, the technique of taking one 2D image at a time, which is a very thin slice, while standing next to the patient for over 20 minutes, is really no longer feasible. 2D really is not enough anymore. We need to have an entire volume that we can navigate through and reconstruct any plane that we want within that acquisition and gain control over all of the planes and all of the anatomy and the displays. Now, I was a radiology resident a long time ago, and at that time, a CT scan took 30 minutes to do. Now, recently I had a CT scan and it only took 2 minutes to do. And why hasn't ultrasound kept up with this? Why are we still taking 30 minutes to do our studies? So I did a study to look at whether we could put the fetus through a 3D ultrasound machine, much like I was put through the CT scanner to get my CT scan. And can we generate a large amount of data of the anatomy, a huge volume that includes all the anatomy, and that can be read elsewhere, off-site. So, for 50 consecutive fetuses undergoing their structural surveys between 17 and 21 weeks, we did their standard 2D scan, one of our 8 sonographers did, and then we further took 5 additional volumes that were designed to encompass all of the fetal anatomy. These included the fetal head, thorax, abdomen, face, and lower extremities, and I'll show you an example of some of these, 2 of these volumes in a moment. And these were designed to try and capture all of the fetal anatomy so that the patient could go home and all of the fetal anatomy could be retained. Now, a couple of weeks after the original scans, the volumes were then reviewed on a separate workstation, and we looked at the time it took to obtain the volumes, the time it took to actually do the surveys offline. We timed ourselves to do the surveys offline on the 5 volumes, including measuring the BPD and the femur. We looked at the completeness of the survey. Were we able to identify all of the landmarks? And we took a look and compared the time it took to do all of that to the time it took the sonographer to do the standard 2D scan. There were 3 physicians involved, myself and my 2 partners, and we reviewed the downloaded volumes. We timed ourselves to see how long it took to review those volumes offline, and of course the physicians were blinded to any of the original 2D information and findings. Now here's an example of a volume taken to evaluate the heart. And let's look and see. Now I took this volume and I'm going to enlarge plane A. This is plane A, and I'm going to magnify it so I can see. Now I'm going to navigate up and down through this volume. Now I'm navigating up and down. I'm getting a 4-chamber view of the heart. Here's my 4-chamber view. And I'm going to go up a little bit above the heart, and I'm going to identify the pulmonary artery. There's the pulmonary artery. I'm going to move my dot. My dot is my pivot point. I'm going to move my dot onto the pulmonary artery, and I'm going to pivot using a Y rotation. I'm going to open up that pulmonary artery so I can see it lengthwise. Okay. Now I'm going to put my dot on the aorta. That's a piece of the aorta just behind the pulmonary artery. I'm going to open it up again using my Y rotation, and here is my aortic outflow. So now I've examined the heart within the volume that was taken by somebody else who may not know the anatomy of the heart, but I had the volume and I could examine it. Now I'm going to rotate the volume back so that it's in transverse section, which is the way I like to scan. And I'm going to go up and down, and now I'm seeing the stomach. I'm going to go down through the kidneys, the anterior abdominal wall, And I'm going to go down and see the bladder. There's the bladder. Okay. Now I'm going to move my dot onto the spine. And now I'm going to pivot, and this is my new pivot point. So now I'm pivoting on the spine, and I can examine the spine from top to bottom very nicely. And I can then navigate through the volume in that orientation, that new orientation, and show all sorts of different planes. Look at the diaphragm, look at the bladder again, look at the bowel, and look at the spine. Now, as you can imagine, there is overlap of these volumes. And you can see the 5 volumes are listed here. And the head volume will often identify, or the head, but it'll often identify also the arms that tend to be in front of the head. Here, for example, is the abdominal volume. The abdominal volume right here will identify most of the abdominal type findings, but it'll also identify the heart about half the time. So there is some overlap with these volumes. That is very helpful. And here's another example. This is a face volume. This was taken to evaluate the face, but we can actually evaluate the brain. And let me show you how we do that. I'm going to take my A-plane, okay, and I'm going to enlarge it first. I'm going to move my dot into the center of the face. And I'm going to use that to pivot with my y-axis. I'm going to move my dot again, so now we're in the middle of the brain. And I'm going to orient myself so that I can see the brain. There's the posterior fossa. And now I'm in a situation where I can actually measure the BPD. I'm going to take my measuring tools. So here's my measuring tool, my 2D distance, and I've measured my BPD. I'm going to go back to the main menu, and now I'm going to navigate up and down. I've got the posterior fossa there, I've got the lateral ventricles, cavum, septum, choroids. I've got all the anatomy that I want here in the brain. And now I'm going to move my dot onto the spine, and I'm going to orient myself at right angles to the initial orientation, and I can navigate back and forth, seeing the spine, and all the way out to the face, which I'll show you in a moment. And there is the face, the nose, and the lips. So we can see a lot of anatomy within that volume. So more than 90% of all of the anatomic landmarks that we look for were identified successfully on this virtual scan as compared to the 2D scans. And all the 3 physicians were equally successful at reconstructing the images and identifying all of the findings. Now the time was really quite astounding, because the mean time that we needed to obtain the 5 volumes was under 2 minutes. 2 minutes of table time. The mean time needed to do the reconstructions varied between 4.8 and 5.5 minutes among the 3 physicians. So let's just say 5 minutes. So the mean time for the entire volume scan was between 6.5 and 7 minutes. So you can see, if you compare the time needed to do the 2D survey, which was 19 minutes, that there was a big difference. In fact, the volume scan saved 12 to 13 minutes per patient. And that's room time. That's time in the room on the machine. For our 50 patients, the total time saved by using this 3D technique was over 10 hours. This suggests an incredible opportunity to increase the efficiency of our scanning in the future, and also to standardize it so that we are not as operator dependent. Now, just to finish up with a few issues that may have come to mind as I went through this, how is the patient going to perceive this? Is the patient going to want more scanning time to view the baby? What happens when the scan is incomplete? How about the sonographer's point of view? Are they going to be able to keep their jobs? And have we increased the time that the physician must put in? As far as the patient perception, this method is probably going to be mostly used to archive the images that we need. Instead of taking them one image at a time, we can take a whole sweep, archive all of the images with one button, and probably still have plenty of time to do a brief real-time component for the patient, and also to look at the heart and the cervix and the placenta. Of course, the patient will need to be educated as to what comprises the medical part of the ultrasound. No other modality prolongs the exam beyond what is medically indicated because it's very expensive to spend time on the ultrasound machine. About 5 to 10% of the exams may require additional views. It's mostly of the hands and the feet that may not be totally included within these volumes in some fetuses. But that should be apparent before the patient leaves, as we can review these volumes very quickly before the patient leaves. In mammography centers, the screening is often done without the physician on site, and there is a small number of patients that get a callback for additional views. And of course, this type of scanning can be done as a screening type. I'm not advocating this for high-risk patients. The impact on sonographers, I think, is going to be very important. The images are going to be less operator dependent. Sonographers will spend less time scanning, and this may improve some of their repetitive injuries problems that they have and that they deal with long term. And then the sonographer can be called upon to reconstruct the views offline, and that will vary their task and hopefully reduce their injuries. And the impact on the physician, well, we'll have some beautiful displays, very similar to CT and MR, because ultrasound is now able to provide some of these large volumes that CT and MR enjoys. And really, ultrasound as we know it today is not going to be economically feasible long term. A 30 to 40-minute session to do a full structural survey one-on-one with a skilled person cannot be reimbursable or cost-effective for long. And plus, once you have these volumes, the physician can then reconstruct any plane, even if it didn't happen to be a plane that the sonographer had planned to image, so that much more information is available within the volume than the information that was actually photographed by the sonographer. So can you imagine if CT scans still took 30 minutes? We need to move ultrasound into the better efficiency, which was previously inaccessible to ultrasound, but is now available to CT and MR. So what do we have in the future? Well, I think 3D ultrasound is likely to really change completely the way ultrasound is done, and certainly the way ultrasound is archived, so that we don't have to take one little slice at a time, but we can take volumes and archive the slices that we want. Improvements in the reconstructed image quality, the speed and the real time is going to be available in all planes with full resolution. That will be even better than we have it today. We will have new innovative displays, such as huge volumes that will be all-inclusive, can even be displayed in real time perhaps, and manipulated completely offline, very similar to CT and MR, but perhaps completely in real time, which will be better than CT. And perhaps 2D only scanning instruments will be relegated to the tiny little miniaturized scanners that you can hold in your pocket. So lots of changes in the future. Volume scanning is only in its infancy, and I think it's a very exciting time to be in the ultrasound community now. Thank you very much.